I would like to thank organizing committee for giving me opportunity to speak on central venous access devices, complications and its management. With increasing and varieties of treatment protocols are being used, some require long duration of venous access and which is very difficult to achieve through peripheral access. Hence, central venous access are commonly used in oncology patients. Unfortunately, it requires high degree of skill in inserting, maintaining, and managing complications. There are several complications related to long-term central venous access devices, especially central line bloodstream infection, which can cause mortality and morbidity in cancer patients. So let's start from first complications, that is central line associated bloodstream infection. It is a laboratory confirmed blood culture in patient who has a central line and there is no evidence of other source of infection. The cause of CRBSI is extraluminal, that is contaminated skin at the time of PICC insertion, or site infection. Intraluminal, that is contaminated tubes, hubs, needleless connector, or infusate. Hematogen colonization is from an infection at the distant site within the body. CRBS symptoms are fever with chills, especially after infusion of medication through the central line, tachycardia, hypotension, vomiting, shock, fatigue, erythema, elevated white blood cell count. Prevention for CRBSI: follow strict sterile insertion procedure, scrub hub of needleless connector prior to each access, practice meticulous access site care, and perform daily site assessment for condition and line necessity. If it is unnecessary line is there, you should remove as soon as possible. Central line associated bloodstream infection is treated with locking the catheter with specific antibiotic. Each institute has their own protocols. So we have locking specific antibiotics for 6 days according to the line prime volume. On the fourth day, fifth day, and sixth day of antibiotic, send blood culture for culture and sensitivity consequently. If 2 reports shows no growth, can use for the administration of line. Now we'll see method for antibiotic locking procedure. Clean the needleless cap with antiseptic agent. Aspirate 3 to 5 ml blood from catheter and discard it. Flush catheter lumen with 2 ml of heparinase saline, that is contain 10 international unit per ml. Lock catheter with a specific antibiotic. Volume should be 0.5 ml in PICC and 1 ml in subcutaneous port or Hickman catheter. Repeat this procedure every 24 hours. Site infection: if any pain, tenderness, erythema, discharge from the site cause site infection. Prevention for site infections is hand hygiene, strict aseptic technique, meticulous site care, and consider use of chlorhexidine gluconate dressing. Treatment: send sites off for culture and sensitivity, do daily dressing and assessment, drain out it if any drain is there, apply antibiotic ointment, and administer oral or parenteral antibiotic if fever present. If symptoms do not resolve within 48 to 72 hours, need to remove central line. Skin irritation or site rash. According to CDC and INS guidelines, site should be clean with chlorhexidine gluconate 2% and ethanol 70% solutions. But it is observed that patients are getting chemical contact dermatitis. Other reasons for skin irritation is medical adhesive that can cause irritation, skin irritation. Symptoms are erythema, presence of macule, itching. Prevention: allow to air dry disinfecting agent completely. Use a low and slow removal technique for old adhesive. Use skin barrier film. Treatment: you need to change the disinfecting agent. Use of topical corticosteroid ointment. Apply soft cotton adhesive. Do daily dressing. Phlebitis means inflammation of the vein. It can be mechanical phlebitis due to injury to tunica intima or movements of catheter within the vein. There are also chemical phlebitis which can cause with the administration of high alkaline or acidic drugs. Symptoms are edema, erythema, pain, warm and palpable venous cord. It can be prevented by adhering to aseptic technique during insertion, utilizing the smallest catheter appropriate for the patients. Insert all components slowly and gently while inserting the PICC. Adequate securement, following guidelines on dilution of solution and drugs. Phlebitis is treated by applications of Hep gel, thrombofoam gel, or glycerin nasal dressing. Give taflogam, that is protolactic enzymes, which catalyze the protein and enhancing the blood flow. Elevation of arms and finger exercises. Applying cold fomentation. Advise not to sleep on affected arm side till symptoms resolve. Venous thrombosis also one complications we are seeing that symptoms are showing edema on full extremity and sometimes patients complain about pain in chest or neck. Prevention: conduct detailed pre-insertion assessment of patient and risk factors. Use of ultrasound to assess vein health, size, and catheter and vein ratio. Avoid extremity with limited movement or range of motion. Correctly position catheter tip. Treatment: consult a vascular thrombosis specialist and administer of low molecular anticoagulant. Occlusion. Occlusion means inability to obtain a brisk blood return or not able to infuse or flush. There are two types of occlusion: partial. Partial means we can infuse or flush easily but unable to aspirate freely blood backflow, or sometimes sluggish flow with infusion. Prevention: flush with adequate amount of solution. Use a pulsatile flushing technique which can be turbulent in the lumen and clear the lumen completely. Be aware of solutions incompatibility prior to infusion. There are two types of thrombotic occlusion: intraluminal occlusion. It can be causing by clotting, thrombotic occlusion, or precipitation of mineralizations or crystallization of drug or solution, or sometimes lipid accumulations. Extraluminal occlusion due to fibrin tail, a flap of fibrin extending beyond the tip of catheter. Other is malposition, especially when catheter tip is touching to vein wall, or pinch off syndrome, like a catheter is pressing by clavicle bone. Treatment for occlusion: you should eliminate mechanical causes like kinking, clamping, or pinching of line. Ask the patient to change the positions like right lateral, left lateral, sitting, or ask to patient coughing. Do popping procedure. Popping procedure means take 10 ml syringe with 5 ml of normal saline, aspirate 4 to 5 ml and hold syringe for 2 seconds. Release plunger, and this action you have to repeat continuously till you feel some looseness in the catheter lumen resistance. After doing this all actions, if there is no success or no free blood backflow, we need to instill thrombolytic injections. If there is any chemical occlusion is there, you have to use soda bicarb. Catheter breakage, symptoms like fuel leakage from the catheter or PICC. It can be prevented by adequate flushing. Do not use forceful irrigation or flushing. Avoid increased pressures, that is, no smaller syringe uses. Avoid use of clamps. Avoid kinking or twisting of catheter. Treatment. Do not leave patient alone. Place patient on his or her left side in Trendelenburg positions. Especially this is for tunnel catheters, where there is chances of catheter embolism. External breakage catheter, we can repair it with repair kit. Now in next slide, we'll see how we are repairing the PICC breakage. First, you check the tear in the PICC, then cut the catheter above the tear, put sleeve and end connector to connector, then both lock sleeve and end connector. Like this, we can repair the PICC. So I can conclude now, center venous access have significant role in management of oncology patients. Hence, meticulous care during insertion and maintenance is crucial. The long interval time is comparison other wards require specific protocols to eliminate life-threatening complications. Thank you.